Hello everyone. Good evening and a warm welcome to you to this webinar on World Encephalitis Day. The topic of today's webinar is Syndrome Evaluation System or Molecular Testing for Informed Treatment Decisions in Encephalitis. At the outset, I would like to thank our speaker, Dr. Ravi Kumar, for taking time out from their busy schedule and enlightening us on this important topic. Dr. Ravi Kumar is the founder of XCyton and functions in the capacity of chairman and managing director. Dr. Ravi Kumar has been instrumental in developing and launching syndrome evaluation system, that is SES, and other products in the market. Now, before I hand over to the speaker, I wanted to inform you that if you have any questions or comments, you can type them out in the Q&A window of the Zoom conferencing browser. We will address your questions towards the end of the session. We will also be sending across the recording of this webinar in case you miss out on any points or would like to revisit some portions later. So without any further delay, I will now transfer the host to Dr. Ravi Kumar, who will take this webinar forward. Over to you, Dr. Ravi.
Thank you. Yeah, good afternoon, everyone. Is everyone able to hear me clearly?
Yes, Dr. Ravi.
Yeah. Good afternoon, everybody. It's indeed a pleasure to really actually participate in a day like this. World Encephalitis Day has been announced, which means many governments have taken notice of this disease. This is really a bad disease that has affected the world for a long time, but general public were not even aware of it. They knew it as some vague term called brain fever in many parts of the world, and everybody neglected it. Now, what gives me great pleasure is now that a day has been identified like this, many governments are paying attention. As I hear today, to commemorate this day, in fact, Vidhan Saudha and High Court and many public places by Karnataka government in Mysore, for example, the musical fountain and all the public places will be lit between 7 and 8 o'clock today, which means the government of Karnataka has taken notice of encephalitis. Now, without much further on this, let us go and see what encephalitis is all about. The World Health Organization has defined encephalitis as clinically any person of any age at any time of the year presenting with acute onset of fever and a change in mental status, either confusion or a behavioral change or disorientation, coma, or inability to talk. And or new onset of seizures which are not febrile seizures or seizures that come in children with fevers. Now, encephalitis, why is it so big? Because it has a prevalence of 67,24,900 people as of Lancet 2019 publication, while yearly incidence is 22 lakh people across the world. Now, it doesn't cause any small amount of problem because morbidity in the form of permanent disabilities, which we call as sequelae, is seen in 20% of the cases, while mortality is sometimes between 20 to 30%, 33% in some cases, depending on the pathogen and the host factors. It is defined as the second leading cause of death in the Lancet paper, which actually described all the diseases of the world, which is a survey done by Gates Foundation. Now, what are the causative agents? There are a whole lot of RNA viruses such as Japanese encephalitis, dengue, West Nile, which belong to flaviviruses, measles, mumps, Nepa, human enteroviruses, which encompasses polio, eco, Coxsackie, and entero 68 to nearly now 78, and rabies, and then Chandipura, lymphocytic choriomeningitis virus, and in Karnataka, especially Casnor forest disease, and influenza viruses. This is among RNA viruses. The moment you come to DNA viruses, you have HSV, CMV, VZV, HHV6, EBV, and all of them belonging to herpes viridae and John Cunningham virus, adenovirus, and parvoviruses. But there are a whole lot of bacteria which present as encephalitis, Streptococcus pneumoniae commonest, Haemophilus influenzae in small children or very old adults, Neisseria meningitis, which comes as epidemics in both in Hajj time in India or any big gathering all over the world. Mycobacterium tuberculosis list. This is a king of any kind of disease, and it is there even in encephalitis. Listeria monocytogenes. Group B streptococcus is very, very common in West. Mycoplasma pneumoniae and a rickettsial fever caused by Orangia tsutsugamushi, which is called scrub typhus, can also cause. Brucella, which comes from animals, Leptospira, and Salmonella and Treponema or the other bacteria. Cryptococcus in Canada have caused mainly encephalitis-like symptoms in India, but there are three parasites: Cysticercus cellulosae, Toxoplasma gondii, and Plasmodium falciparum maximally. Acanthamoeba is a problem specific to people who wear contact lens in this country. Now, what is the need to know etiology? Is a big question. Sometimes people ask, why not we give both antivirals and antibacterials and wait? This is to institute early therapy of herpes simplex virus encephalitis, which can cause 100% cures. Mind my word, it's 100% cure is what we have seen in many cases. And a prompt therapy for potentially fatal bacterial etiologies of encephalitis among rural children, both in Africa and India. And to withdraw acyclovir within 24 hours of initiation after determination of etiologies other than herpes virus. To determine supportive therapy and hospitalization, ICU admissions, all those things, if you know the etiology, you're much better placed. Of course, to epidemiologically determine what is the disease burden of each specific pathogen and determine preventive interventions of outbreaks and to determine immunization strategies for the countries. All this need to know the etiology of this. So for this, the whole lot of battery of diagnostic tests available, from simple CSF smear on a slide, looking with gram stain for bacteria, India ink for Cryptococcus, and then of course culturing for bacteria and fungi, antigen detection for pneumococcus, including by the way Haemophilus influenza and Neisseria. There are antigen tests available. Cryptococcal antigen, ESAT6, Mycobacterium tuberculosis, and beta-D-glucan testing for Candida, and then a whole host of IgM and IgG capture ELISAs for Japanese encephalitis, dengue, West Nile, chikungunya, HSV1 and 2, CMV, and then, of course, IgM capture ELISA in serum for Chandipura virus, and IgM and IgG capture ELISA for toxoplasmosis. Now, then there is a whole lot of virus culture for enteroviruses, which has been extensively promoted. It is probably done in about 5 to 6 centers in this country, while PCR tests are more popular. They are available for HSV1 and 2, varicella zoster virus, enteroviruses, Mycobacterium tuberculosis, cytomegalovirus, human herpes virus 6, JC, Toxoplasma, pneumococcus, meningococcus, and H. influenzae. All this host of tests are available. How do you use these tests? It is said that in every encephalitis presence, like a syndrome, which are most of them are common features, either fits or disorientation after a few days of fever. Now, the number of tests that I enumerated are used like an algorithm, and there are about 41 tests, by the way. I have not been exhaustive in my list previously, and those are administered like an algorithm. That algorithm is what is being explained. You look at microscopy. If it is positive for gram stain India ink, done. If it is negative, then take it for antigen detection for both pyogenic bacteria and cryptococci, and then also do antibody detection for toxoplasma. Now, if it is antigen detection negative, the negative then is taken to culture. If the culture is negative, is taken to PCRs, but for both pyogenic and Mycobacterium tuberculosis. Now, antibody detection to toxoplasma, when it fails, you do PCR. Now, in the next, we are looking for an algorithm of acute encephalitic syndrome sample analysis for viruses now. There is antibody screening and antigen detection. Antigen detection is done for rabies in the form of immunofluorescent test on corneal smears, and that is done. And antibody screening is done for IgM capture ELISAs, which I had described for JE, dengue, West Nile, HSV, chikungunya, and whole lot of them. And when they are negative, you take them for virus culture. And it's much, much rarer. It's done in about 2 to 3 centers in this country. And then once it is negative, it is taken to an RT-PCR, which I described the list of various PCRs in that. Now, in antigen detection, when in rabies, is when that fails, then you look for PCR. Now, this is the algorithm. So many tests in a sequential fashion are done. Now, what we thought is we need this. Actually, what happens in the sequential analysis is 2 things set in. One is delay in knowing what is causing. 2, in the clinician, there is sometimes a fatigue sets in of what I call as investigational fatigue or diagnostic fatigue. This is what we call as disease-based diagnosis. You first look for A, when that is not there, you look for B, then C, then D, and up to N you look. Now, instead, can we look for all of them in a single sample, in a single test, and all A to N in one single test? That would be called a syndromic approach. And that's what we have done at XCyton. And we created syndrome evaluation system. It's a molecular diagnostic method that uses patented reagents to detect pathogens in life-threatening infections. It's not only for encephalitis, it's also for meningitis, sepsis, febrile neutropenia, and post-transplant infections. What does it do? It reduces mortality, makes diagnosis faster, detects 4 times more than all conventional tests, and facilitates targeted therapy, reducing antimicrobials by 50% in all the cases we have demonstrated. And of course, overall reduction in the cost. Now, what is the technology we are using? We are using the following technology. We actually prepare the DNA and RNA from a sample. We extract that out and do with that, if it is RNA, we convert it into a cDNA and then do all DNA and RNA, we do a multiplex amplification, in which case anywhere from 11 genes to nearly 29 genes are tested in a single sample in a single tube. So we amplify for all of them. Something got amplified. In this small 50 microliter volume, you wouldn't know what got amplified. So for detection or revealing what got amplified, we do what we call as sequence-specific hybridization on a solid surface, where the amplified product is asked to engage with or hybridize with the synthetic oligonucleotide probes, which are signature sequences of all the genes that we amplified in the tube. And wherever it binds, it then is converted into a visual signal and in a grid. Like square number 1 means one pathogen, 2 means another, square number 1 means it's a HSV, one gene, 2 is second gene, 3 is third gene, 5 is CMV gene. Like that, you can actually do an analysis and find out what came in. Now, there are some unique features of this massive multiplex that we do. One is we detect only pathogens, no commensals. And for this, we have chosen genes which are virulence associated or markers of virulence or pathogenesis in these pathogens. For example, among bacteria, we don't look at 16S ribosomal RNA or 23S ribosomal RNA and fungal 18S RNA. Genes are avoided in this case. So each gene is specific to one pathogen, but it is conserved among all strains. Let's take strep pneumoniae. we have tested our strep pneumoniae primers against 13 different strains of strep pneumoniae available in this country, which are seen frequently. Now, this is what we call as our SCS panel. We have, first, I want you to focus where I am putting my my arrow cursor. Here, this is acute encephalitic syndrome, SCS. It contains Streptococcus, Haemophilus, Neisseria, Mycobacterium tuberculosis, Cryptococcus, HSV, CMV, VZV, HHV6, JC virus, and of course, it contains Japanese encephalitis, dengue 124, West Nile, enteroviruses, chikungunya, rabies, Chandipura, measles, mumps, rubella, Nepa, and Toxoplasma gondii. And we have combined the DNA part of this, which are all treatable conditions of this, and put them along with all the bacteria that cause even meningitis and called it pan-CNS, which is on the left-hand side of the screen here. And we have another important panel here and again on the right-hand side. This is Outbreak Panel, in which only RNA viruses which cause outbreaks are investigated. Then we have what is called sporadic encephalitis, which contains all the DNA organisms, such as the 4 bacteria, the Cryptococcus, and the 6 DNA viruses, and the Toxoplasma gondii. Now let's look at what is the sensitivity and specificity of big multiplexes of this kind. We have, first, that I am trying to show you the data which we got in EQUAS, that is external quality assessment done by a EU notified body called QCND in UK. Now, in this graph, you can see the yellow bars are the results of XCyton. The blue bars are the aggregate average result of the rest of the labs participating in that EQUAS. This, by the way, from India, there are only 2 labs which go now and then. One lab is constantly ours, another 1 lab. Otherwise, it is not done. For few parameters, they come. And you can see here in the HSV1, our yellow bar is 100%. We got 100% correct results in this, and totally 291 labs participated in it. And the average of the rest 290 is this blue. So in other words, we performed fairly well in this assay. Same thing vis-a-vis CMV, VZV. But look at HHV6, it gave only 82% positivity in our case. This is the only place where we have not got 100%. All other parameters, whether Epstein-Barr virus, JC virus, BK virus, adenovirus, enterovirus, West Nile, dengue, pericoviruses, this is Enterobacteriaceae, and Toxoplasma gondii, Aspergillus, Candida, all of them have given 100%. Now let's look at specificity of this proficiency. Again, yellow bars here represent XCyton's data. They're 100% in all the cases. Now, specifically, we've also gone and tested against panels which are meant for multiplex assays like ours. When we do that, you can see this is for bacteria, Neisseria meningitis. We have identified correctly. Rest of the labs 95%. 95% here. And when it came to Streptococcus agalactiae, we got 100%. Rest of the labs put together, aggregate is 72%, like that. This is the negative, correctly identified. Strep pneumoniae, 100%, and Listeria monocytogenes here, and Haemophilus, and E. coli. Now, similarly, we have done for also a viral pathogens of the CNS. You can see pericoviruses and enterovirus, JC here, HSV here, HSV1 to HSV2, VZV, and a negative. You can see we have again done exceedingly well, giving 100% on this panel so far. Now, we are an NABL accredited lab because a lot of data of our lab I'm going to summarize on an important date. I thought I should share some of our observations, which we believe have important implications on clinical practice in this country. First, what we have done is actually our acute encephalitic syndrome, which we have collaborated with NIMHANS, with Dr. V. Ravi, and produced, has been extensively validated at NIMHANS on many cases. And this validation has done our SCS versus the algorithm that I described in the beginning of this talk of 41 tests. You can now see, first we have got 51 pathology proven cases. Out of them, 48 we detected. Now let's see what these cases are. There are 10 cases of Cryptococcus, 7 cases of Mycobacterium tuberculosis, 13 cases of Toxoplasma gondii, 6 HSV cases, 5 JC cases, and 10 rabies cases where we missed 3 of them. These 3 were missed in CSF but not in tissue, which meant we lost the detection of this because of the sequestration of the virus into the brain compartment, parenchymal compartment, which happens. And that's why probably most of the rabies tests are, when compared to this tissue biopsies, it is actually 70%. We have landed there. Now, then we have tested 207 cases of acute encephalitic syndrome. And all of them are run on the 41 algorithm of 41 tests. Out of them, they gave 77 positives. Now, what are these cases? You can see here, there are enterovirus positives 11. There are HSV positives 13. There are chikungunya IgM positives 7. Measles IgM 1. Dengue IgM 1. And we picked up the RNA out of that in those cases. Even more interesting is among cases of immunosuppressions and HIV cases, we got Streptococcus neoformans. In 2 cases, we actually detected Cryptococcus neoformans plus strep pneumoniae. Among Toxoplasma gondii cases, 1 Toxoplasma gondii plus CMV, Toxoplasma gondii plus Cryptococcus has been detected. Among immunocompetent individuals, among 4 children whose samples came from Northeast to NIMHANS, we got Neisseria meningitis and strep pneumoniae polymicrobial detection. So we got 77 out of 77, which have been detected by the 41 test algorithm. We also detected, and not only that, we also detected polymicrobials, additional ones here. Now, there are 130 negatives in that algorithm. Out of that, we got 83 positives. What are these? This is the list of 83 positives. Out of them, HSV predominated, 26. There is strep pneumoniae, 15. Mycobacterium tuberculosis, JC, enteroviruses, chikungunya. Otherwise, if you remove JC, enterovirus, chikungunya, the rest are all treatable conditions. There are specific therapies for them. Now, how do we know that these are actually specific positives? What we have done is, wherever there is sufficient CSF, it has been subjected to sequencing, DNA sequencing, and that resulted in actual identification. That's what we said, sequence confirmed that what we identified as pathogen is the same pathogen that is there in the sequencing. Now, not only that, we have detected some polymicrobials here too. Some of the polymicrobials were subjected to sequencing. In fact, majority of them, and all of them came exactly correct. So overall, this trial shows us additional something, that is, we have chronic CNS infections, TB plus Cryptococcus 20, we detected all of them, and non-infectious neurological disorders, we took 90. Out of them, we got 12 positives. Now, what are these 12 positives? These non-infectious neurological disorders, these 12 are brain tumors on chemotherapy. There are additional 10 brain tumors which were operated, but there was no chemotherapy in those patients, we didn't see the latent viruses such as HHV, 6, CMV, and HSV in these patients. Now, we have also done healthy controls 50. What do these healthy controls means? These are women being subjected to spinal anesthesia at various hospitals, and the CSF taken at the time of spinal anesthesia is given to us through Karnataka government's permission, and we tested them. None of them are positive for any pathogen or a latent virus. In other words, we have given a 77% detection of pathogens among all these cases, while the algorithm of 41 tests, here it is very important to mention that 41 tests together will cost more than 65 to 70,000 rupees a patient, even in a place which is run by Government of India. So that is versus that we have given a 77% much higher level of detection in AES. We were concordant with all known positives and concordance with known negatives, and additional detection, which we confirmed by sequencing, and detection of polymicrobial neuroinfections, which is important to give a complete comprehensive therapy to bring the patients out of this. Now, apart from that, we have also done studies with MS Ramaya Institute of MS Ramaya Medical College, where their Institute of Neurology tested. They have published. I'm not discussing much and of that, except that they have, in that study, said that they stopped in 16 cases acyclovir after we reported a HSV or any herpes virus negative. And all those cases on follow-up did very well. Similarly, we have done a study with KG Hospital, Coimbatore, Dr. T.C. Ramakrishnan's place, and there too, he has done 9 cases. He stopped acyclovir because we reported HSV negative. And in those cases, again, on follow-up, they have all done exceedingly well, which means our diagnosis was our negative predictive value is very good in this test. Now, I thought I'll put something across. We have done now totally 22,000 various samples. Out of them, more than 12,000 samples belong to central nervous system. We actually analyzed for 3 years what are our results and what do they tell us in using certain AI algorithms, that is artificial intelligence algorithms. As you can see here, most of our samples came from South India, a few from Delhi, a few from Rajasthan, and a good number from Bombay too. Now we have analyzed 6,074 CSF samples which have been received at XCyton Diagnostics and where we have given a report. Now, we obtained the data of symptoms and clinical signs, CSF cells, protein and sugar, CT MRI results, and wherever the data is incomplete or inadequate, we did not even take. 700 cases were dropped, and the only 6,074 were taken, even though originally we were taking 6,800 cases. And we have not considered follow-up data for analysis, and all presentations were either acute or subacute. All patients received anti-infectives for more than 3 days in a tertiary care center. All the samples came from tertiary care centers. We actually divided them into rule-in criteria. That means a sample came to rule in an infection. Here, if we suspect the clinician is going to continue antimicrobial therapy in spite of we giving a negative, we called it a rule-in case. We missed it is what we considered. And any single criteria where a provisional diagnosis is strong, such as meningoencephalitis, meningitis, TB meningitis, pyogenic meningitis, viral, bacterial, fungal, all HIV patient cases were considered rule-in. Septic encephalopathy is rule-in. Neonatal meningitis, either late onset or early onset, is rule-in. UTI, urosepsis, pneumonia, partially treated meningitis, all of them are taken as rule-in. And anybody came with premorbidities and risk factors such as transplant patients, cancer patients on chemotherapy, road traffic accidents, head injury of any other kind, people who are ventilated, people who had shunt operations or a craniotomy, or had an operation for sinusitis, osteomyelitis, dog bites, all of them were taken as ruling. And here, in addition, we also looked at CSF. CSF had rage cells, elevated protein, and low sugar. CSF gram staining, any culture report, all of them, any positivity means it's ruling. Imaging data saying anything like basal exudate, leptomeningeal enhancement, meningism, an infarct, brain abscess, or an SOL, or a hypodensity, a hyperdensity, whatever, all of them have been taken as ruling. And similarly, any specific signs such as seizures and all have been taken as positives. Now, the rule out is where clinician said I sent it to rule out, or he has put diagnoses such as demyelination disorders, metabolic encephalopathy, autoimmune encephalopathy, and psychiatric patients on some, in order to rule out some organic causes, Parkinsonism, status epilepticus under evaluation, vasculitis. And in all these cases, there has to be CSF normal picture and imaging data has to be normal. Then we called it rule out. Now, if you see, we have got about 3,608 cases with rule-in. Out of them, we got 38% positivity. Among rule-out cases, we have got 2,361, only 56 or 2.3 were positive. In other words, largely this diagnosis went in correlation with clinical presentation and what the clinicians decided as. Now, what are the organisms? The rank order of the organisms are Streptococcus pneumoniae and Mycobacterium tuberculosis, herpes simplex, varicella zoster are on the top 4. Now, you can also see we have got cytomegalovirus, 54 cases, neurocysticercal antibodies in 59 cases. We had herpes, human herpes virus 6 in 43 cases, John Cunningham virus in 27 cases, and Haemophilus influenza 13 cases, and enteroviruses 9, and West Nile 6. In all, we also had a Nepa case. In fact, the Nepa outbreak of 2019, which is a single case that occurred in Kerala, we reported it first, and Kerala government was alerted immediately, and they isolated all the people who treated the patient, who are connected to the patient, and prevented an outbreak in 2019. Now, among all these cases, here focusing back on the encephalitis, this is the main point I wanted to make here, is that we asked the question, among these cases, is there a classical meningitis and classical textbook presentation of encephalitis? Yes, we said fever, seizures, altered sensorium, MRI lesions in brain, and CSF cytology says greater than 5 cells, and 60% of them are lymphocytes. We had got 532 positives for this encephalitis-like picture, and out of them, SCS detected pathogens in 127. There is only 24% detection. When we did our analysis, we understood that 90% of the 532 cases, they asked for only our SCS, sporadic encephalitis, as the test. That has been the major test done in all these cases. Now, why so? Because this SCS syndrome evaluation system of sporadic encephalitis or meningoencephalitis, it used to be called earlier, what it does is it looks for all treatable causes of encephalitis. It looks for HSV, CMV, VZV, HHV6, JC, then toxoplasma, then the 3 classical bacteria that cause meningitis as well as encephalitis, Mycobacterium tuberculosis, and Cryptococcus. So that is the test most popular among clinicians, and they ordered it. So we have missed, or we have not investigated for a whole lot of other pathogens which cause, like enteroviruses, which cause frequently encephalitis. Now we found another thing here. This is the major point. We asked the question, what are the pathogens among when patients presented with encephalitis, and what are the pathogens in meningitis? In encephalitis, we expected viruses to be the predominant pathogens. Instead, we got 37 cases caused by viruses, and bacteria caused 94, and fungi and parasites caused, parasites means mainly Toxoplasma, caused 2 cases of encephalitis. This looked a little worrisome, as most of us assume when we say encephalitis, we are also talking about lymphocytic predominance that could come due to somebody treating a patient with antibiotics at a primary or a secondary health center before the patient came to the tertiary healthcare center where we have done this diagnosis. But however, why is that bacteria causing? Is this true phenomenon, or is there an artifact in this? We looked at, after all, our out of the top 4 or top 3 organisms of Strep pneumoniae, Mycobacterium tuberculosis, and HSV. So we asked the question, what are the presentations? Among 286 cases of Strep pneumoniae, 160 presented with encephalitis-like clinical picture. Among about 99 cases, among 259 cases of Mycobacterium tuberculosis presented as encephalitis picture. 66 cases out of 125 HSV also presented as encephalitis picture. Seizures, altered sensorium, behavioral abnormalities, and so on and so forth. So here is the red flag that we would like to put across to everybody. Now, as I was talking about the previous slide, we found bacteria seem to be causing an encephalitis-like picture, which is not what is expected from all that we studied either in our medical schools or neurological, wherever neurology institutes we have been trained. So we asked the question, how do the top 3 organisms, one is Strep pneumoniae, second is Mycobacterium tuberculosis, third is HSV, how do they fare with respect to presentation as encephalitis? If you really look at it, Strep pneumoniae, 160 out of 286 cases presented as seizures and altered sensorium or behavioral abnormality. 99 out of 259 cases of Mycobacterium tuberculosis also presented with these symptoms, seizures or altered sensorium or behavioral abnormality. Same thing is HSV. HSV, where we expect these are the predominant symptoms, 66 out of 125 presented there. So this actually gives us one new red flag. Wherever you see encephalitis and you see lymphocytic predominance, we tend to conclude it is a viral encephalitis. It may be true until you ascertain that there was no antibiotic treatment given before that. Once an antibiotic is given, you get lymphocytosis and the picture gets complicated, and it will look like a viral encephalitis. And encephalitis-like picture plus viral encephalitis like CSF picture looks to you very convincing it is an encephalitis, and they start acyclovir and not an antibiotic or an anti-tuberculous treatment. So we believe this is a very important feature. Next slide. In the next slide, we actually probed what happens to various MRI findings when people come with various CNS infections and some encephalitis as well. We find that positivity rate is anywhere from 13% in case of normal MRIs, 13% of the cases we gave some pathogens, while it goes up to 44% in hydrocephalus. Now, let's go to the next slide. It even becomes more clear that you will see that the viruses which are given in blue or turquoise blue case, 15 cases of viruses were found in normal MRI picture. And even what radiologists suspected as tuberculosis, we got 6 cases of viruses. We also got in ring enhancing lesions 4 viruses. So we need to understand that in spite of MRI finding being normal, we might be able to, even though there is only 13%, we will have a chance of finding a pathogen. And it's important to note the cortical infarcts were always ascribed to tuberculous lesions of the brain earlier, but not anymore. There are a lot of bacteria, other bacteria, and Mycobacterium tuberculosis, of course, caused, and even fungi and viruses caused cortical infarcts in many cases. Just I wanted to take this also as an important take-home lesson in our huge study. I'm not presenting all the data because this is not totally infections of the brain, but it is actually encephalitis, and we are trying to ascertain ourselves that we need to find out what is causing encephalitis from this day onwards, and every time investigate it and then appropriately treat it and bring most of them to normalcy. That's our aim. Next slide. Now, how do you use these diagnostic algorithms using SCS? This is a quite of how do I use your test is what doctors ask. So I thought I will mention that. Next. Patient suspected of CNS infection, and let's next quickly. Yeah. A fresh case, 7 days antibiotic name. If it has lymphocytes, send it for acute encephalitic syndrome. No questions asked. Please press. Yeah. Then that is meningoencephalitis or RNA viral panel, depending on what you're suspecting, or AES. That's what I'm saying. Now, treated elsewhere for 5 days, combined picture of meningitis, encephalitis, please do pan-CNS and RNA viral panels. Quite often that would be required. Next. And suspected meningitis, sepsis, then you need to send 2 samples, both blood and CSF, so that we actually give you a clear picture. That's a separate story. Next. I think here is treated elsewhere. Meningitis is predominant clinical picture. Do meningitis, but in case last, to rule out fungi, bacteria before start of immunosuppression, again you do meningitis, but to rule out viral etiology, you have to do acute encephalitic syndrome. Next, if you detect a pathogen which is same as what you suspected, well and good, that means you got certainty for your therapy. If it is positive, but pathogen is not covered by your empirical therapy, already you have started, then escalate specifically. Now, I am detecting a pathogen which is not clinically suspected. This bothers a lot of us as clinicians. Why did this happen? But I think in case of brain, which I consider as a black box, it's escalate the necessary. If find necessary, patient is not improving, escalate according to the new unexpected pathogen found. Well, when there is no complete negative, think beyond infection. We have seen in case of HS, people treated for HSV for a month. When we said no, it was not HSV. The patient came back after 3 months. There was a tumor found in the same place where the first MRI lesion was seen. So it is looking for other things beyond infection is also important. Next slide. So in summary, every hour 75 people die because of encephalitis in this world, according to the Gates Foundation's entire survey of 182 countries and their data, which was published in 2019 in Lancet. Now, every hour, 55 people get permanent life disabilities. And this is not ordinary. It's a huge burden on society. We need to be careful about brain infections and especially encephalitis. Early diagnosis followed by appropriate therapy will reduce morbidity and mortality burden by 60%. This we have demonstrated in a couple of papers. One is especially what is published from MS Ramaya on 129 cases by them. It is very clear that they have prevented disabilities. SCS AES or SCS sporadic encephalitis or SCS outbreak encephalitis will give highly specific diagnosis within 6 hours in more than 77% of the cases. So please use and treat appropriately. Streptococcus pneumoniae and Mycobacterium tuberculosis of CNS present as encephalitis more than meningitis. This is a take-home lesson for all of us because these two are very common pathogens in this country. I think I will close at this. Thank you all for a patient hearing, in spite of some techno glitches in this Zoom presentation where my slide presentation had to be transferred out of site and represented. I know all of you bore with it. Thank you very much. And I'm willing to take any questions. You can send it by chats.
So there is a question from Dr. Rahul that what is the sensitivity and specificity of toxo PCR? What sample to choose?
This toxo PCR, we have got actually so far 100% result. As you can see, in NIMHANS at 13 cases, and we have a lot of toxoplasma cases even in the so-called parasitic both meningitis as well as it presented as this one. We have actually got so far, and the sample choice, there is only one sample for all encephalitic panel, that is CSF.
Okay, I think that answers a question from Dr. Prabhupad also, who was asking, can any other sample be used apart from CSF for meningitis?
Okay, no, really not. See, only because textbooks classically said you can also pick pneumonia and Neisseria meningitis, which first start as a sepsis, you can pick them up in blood. But because people do get some antibiotic therapy or the other, that reduces the chances of you finding it in blood or any other place. So, any other?
So we have one question which I think we have addressed during the webinar, which is what is the syndrome evaluation system and what is the stepwise approach for this?
Yeah, in fact, I know that it's a nice question and we have answered partly, but I would like to put another word here. It's not a stepwise. It's a one-step look at entire encephalitis or entire any syndrome, whether it is meningitis or sepsis or febrile neutropenia. It's entire look at one shot.
Question from Dr. Archana Kher, and she wanted to understand what is the percentage of getting positive results on syndrome evaluation system.
There are two kinds of percentages. If you ask for a laboratory level trial, which we have done in EQUAS, we almost got 100%. It is meaningless to say I have 100% sensitive, 100% specific test because they are limited samples. But when we have done over 12, so many thousands of cases, in spite of treatment, we have got, if people have asked appropriately, then we go up to 54% to 61%. Overall, we got 38% to % positivity in all the cases.
Okay.
What is the comparison to the conventional test? Conventional tests have given in these cases about 2 to 6% positivity. I think that is the thing. Now, when you look at EQUAS, International Quality Assessment done through International Quality Assessment done through QCMD, we will always know that it is due to, it is 100% sensitivity and specificity. So, if actually the whole trick of the trade seems to be sending the sample on the day one. When people sent within the first 3 days, like the cases with 119 cases that we investigated at Ramaya or at KG Hospital, about 76 cases, where it was purposely, we tested it before third day. In those cases, we got 61% positivity. So the so-called specificity sensitivity is not 100% at laboratory level, but I think practical level, if I have treated a patient for 3-4 days, then I understood it is a CNS infection. I am sending a sample now. What is my probability? It is up to 54% to 61%. That is the truth. And if it is much more than that, yes, it may fall up to 38%. And for that, when you have a viral illness, you need to investigate fully, not only treatable conditions. Then your chance of getting a perfect diagnosis is better. Yeah. Another frequently asked question is, for all these, people do ask questions like, do we not look for enteroviruses in stool sample? Do we not look for dengue and Japanese encephalitis in West Nile in blood and so on and so forth? Very frequently asked question. My answer to that is, they are all not proof. Even if you get a JEV in the peripheral blood, it is not a proof that you have an encephalitis. But if you have it in the CSF, it's a final proof. That's exactly. So I think, and CSF TAP is only contraindicated if there is a lot of brain edema, as seen by papilledema, and otherwise, in many cases, neurologists easily would like to do CSF TAP.
I do not see any further questions. So I think that's about it for the webinar.
Yeah.
I would like to thank Dr. Ravi Kumar again for talking to us on this important topic. If the audience has any more questions or comments, please don't hesitate to get in touch with us through our website or email it to us at diagnostics@medgenome.com. So thank you again for attending this webinar and hope it was beneficial. Until next time, goodbye.
Thank you. Thank you.